Hey guys, welcome back to it. So today we're going to be discussing our first chapter focusing on diagnosis. More specifically, what we're going to be covering today are going to be the anxiety disorders, and then we're also going to touch on some trauma and stress-related disorders as well. First things first is you guys should review these two introductory slides on the concepts of stress and anxiety. These are likely familiar terms to you, but these are going to be some specifics that you'll need to be familiar with for this class. In particular, I like to emphasize for students that stress, broadly speaking, is the disruption of homeostasis, which for humans also includes anticipation, meaning that humans can become stressed out by just the expectation that the status quo may be disrupted, and that stressors can be a variety of physical or psychosocial types of things, including injury, violence, sickness, also more psychological, such as types of things like significant life events or relationship issues, et cetera, et cetera. At the end of the day, all stressors are going to trigger a physical response, the same physical response, and you can see the exact symptoms of that physical response listed out under the sympathetic division image on the right-hand side of the screen. Broadly speaking, we're talking about blood and resources going to our body's heart, muscles, as well as the veins and the brain, while resources are going to be going away from less critical parts of the body, like the digestive system, the reproductive system, the immune system, things like that. And we're going to see a lot of these symptoms of sympathetic nervous system activation crop up later on once we get to the symptoms of anxiety. Anxiety is, in a nutshell, a future-oriented type of worry, typically with a negative twist to it. Generally, this worry is in reference to newer situations and is time-limited. The abnormal type of anxiety that we'll be talking about today is going to be anxiety that lasts and lasts and lasts and doesn't expire, or alternatively, anxiety that is irrational or not relating to something that is truly threatening. And you can see examples of that listed out under everyday anxiety versus an anxiety disorder. For example, an example of everyday anxiety would be something like a realistic fear of a dangerous object, place, or situation, versus the disordered version would be an irrational fear or avoidance of an object, place, or situation that poses little or no threat of danger. At this point, you guys should have already watched the video highlighting Miriam and her snake phobia. We have also already discussed the behavioral theory of anxiety disorders and how they developed in class. So moving on to what we'll be focusing on today, which is going to be the anxiety disorders. Last bit of preliminary info is going to be basic shorthand that you guys will need to know for just lectures in general in this class. I use a lot of this on my slides just to condense a little bit what I'm saying. With your class more so than with other classes I teach on diagnosis, I try to use as much of the DSM's actual verbiage as possible, just so you can kind of get the flavor for how the APA is describing these disorders. That means that my slides are wordier than I would typically write if I were kind of writing them using my own words. And so I use a lot of shorthand to get the APA's language onto these slides while also keeping the size of the font reasonable. So if you need to reference back, this is what a lot of that stuff means. You're not going to be quizzed on this. This is just for your own reference. Okay. So the very first thing that we're going to talk about diagnostically is the panic attack. First thing to recognize about the panic attack is that a panic attack is actually not diagnostic in and of itself. So as a clinician, I would never diagnose a person with panic attacks, quote unquote. We cover panic attacks in the DSM, however, because they are a building block to other disorders. So we need to define them, and then we'll reference back to panic attacks later. The panic attacks by themselves just this are not something we're going to be diagnosing folks with. So what is a panic attack? A panic attack is an abrupt surge of intense fear or discomfort that reaches a peak within minutes and includes at least 4 symptoms. From this list of symptoms, we're going to be seeing primarily physical types of symptoms. You'll also recognize many of these as indicators of sympathetic nervous system activation. So a panic attack is functionally just the sympathetic nervous system turning on really, really fast. In addition, you'll also see towards the end of the list that we've got a couple of more cognitive types of symptoms. So our thoughts and feelings can play a role in the development of a panic attack as well. So we've got 12 different symptoms on this list. And again, we're just looking for 4 more in order to diagnose a panic attack. So we may see cardiac symptoms like palpitations, a pounding heart, or an accelerated heart rate. That's one symptom. We may see sweating. We may see trembling or shaking. We may see shortness of breath, or just the notion that the person's having a difficult time getting air or full breath in. The person may also be experiencing chest pain or discomfort. We may see nausea or abdominal distress. We may also see just any kind of lightheadedness. This could also be dizziness, faintness, just the person feeling a little wobbly or unsteady. We may see temperature sensations. The person may be hot or cold, more specifically. We may see paresthesia, which is a fancy word for numbness or tingling. And generally, these are going to be felt in the extremities. So fingers are typically the most common one. You might also see toes as well. Derealization is going to be our first cognitive symptom. Derealization is a feeling of unreality. Alternatively, we could also see depersonalization, which is a feeling of being detached from oneself or an out-of-body experience. So derealization is just kind of the sensation that you are really separated from what is happening and you're kind of questioning the reality of what's going on around you. Depersonalization really is an out-of-body experience. That's kind of how I like to describe it to folks, just feeling like you're floating above yourself or otherwise detached. We may also see a fear of losing control or quote unquote going crazy. DSM's words, not mine. And then finally, we may see a fear of dying. So again, we need 4 of these symptoms peaking within minutes in order to diagnose a panic attack. Panic disorder then is going to be our first full disorder that we could diagnose the DSM. And as you may have expected, panic attacks are a building block of panic disorder. So criterion A for panic disorder is recurrent unexpected panic attacks. 2 key words there are recurrent and unexpected. So recurrent means more than one, unexpected means random in nature. So there is not a reliable cue, but instead the panic attacks are random, by surprise, unexpected. The panic attacks can occur from a calm or an anxious state. A lot of people don't realize that panic attacks can occur when a person is relaxing. I once worked with a woman who developed panic attacks that struck in the evenings and at night when she was relaxing. So it's entirely possible to even have like nocturnal panic attacks. Another note is that you may see culture-specific symptoms. So this could include things like tinnitus, which is ear ringing, neck soreness, headache, uncontrollable screaming or crying. It's important to note these things, but remember that the DSM is very specific. So while you may note these things, you should not count them towards the total of 4 symptoms that you're looking for per the DSM. At least one of the panic attacks has to have been followed by 1 or more months of one or both of persistent concern or worry about additional attacks or their consequences. So potentially worrying about having a heart attack, for instance, or some other physical ramification of your attacks. Or a significant maladaptive behavioral change related to the attacks. So the person may begin avoiding things in an attempt to avoid the panic attacks altogether. Ultimately, this second criterion, this criterion B, is really what explains the development of the panic disorder. Panic attacks by themselves, as you guys will see on the next slide, are relatively common. They're also completely safe. They're not fatal, they're not dangerous, but they're really scary, and they can resemble a cardiac scenario. You know, your chest feels tight, your heart's hammering, you're sweating. So it's pretty common for people to confuse them for a cardiac event, or even to call 911 or go to the emergency room. And it's really that anxious, fearful reaction to the panic attack, that fear of fear, as I like to call it, that sets up this loop, this panic loop that creates the panic disorder. When people become afraid of additional fear or anxiety and they begin worrying or changing their behaviors, it's actually that piece that perpetuates the attacks and makes it more likely that the person will continue to have subsequent ones. To highlight this, I always like to tell students about my first panic attack. So I haven't really had too many. I've had maybe like one or two since this first one, but this first one is really poignant for me, and it highlights how you can break out of this panic loop. So what happened to me is I was visiting a friend of mine, also a therapist, and she was working in Wilmington at the time, and she was getting ready to move back to the high country. And before she left Wilmington, she wanted to do all the touristy things, the things that you don't really do when you live in a place, but you sometimes will do, you know, before leaving, or if you're a tourist in that spot. So on her bucket list included the battleship North Carolina. For anyone who hasn't been there, Wilmington has this big old battleship that you can tour. And I agreed. It's the middle of the summer, by the way, which is important to the story. And so I agreed. You know, I'm a pretty easygoing person. I was like, yeah, sure, you know, we'll do whatever it is that you want. We get out there, it's hot. And the tour basically entails walking through the ship. And I didn't really realize that once you got in there, it's just a bunch of arrows prompting you forward. There's no way to exit the tour in the middle. It's not like going to a museum where you can decide that you're done and you want to leave. You have to just kind of keep going. And there's no indicator as to how far in the tour you are. You just keep going. And then when it's over, it's over. I also have a slight claustrophobia. I wouldn't even use the word claustrophobia, because if we reflect back to what we talked about in chapter 1 about distress and impairment, I wouldn't really say that I am impaired in any way by my claustrophobia or that it upsets me. I just like having an air hole. I like having access to air. That makes sense to me, and it doesn't get in the way in my life in any way, but I do like having air and I don't like just being surrounded by walls and hot air. And so we get in here and I just kind of start panicking. I start feeling really hot. I have a tough time breathing. I can kind of feel tightness in my chest. I'm shaky. And of course, you know, because I am a therapist, I'm just quietly ticking off my symptoms. I'm like, oh, I think this is a panic attack. And because I'm an educator, I also always find it interesting when I have a clinical experience. Part of me, of course, is like, oh, this doesn't feel good. But part of me is also like, oh, this is interesting. This is what this is like. Nonetheless, though, despite my curiosity, it didn't feel great. It was uncomfortable, but my friends seemed to be having such a great time. And so I just kind of swallowed it and just pretended to read all of the signs and tried not to rush her because this seemed important to her, and just kind of suffered on. And eventually we get back out onto the deck and we both exhale so loudly and then look at each other, and we quickly realize that both of us hated it. Both of us were quietly panicking, but we thought the other person was having a good time. So both of us were just quietly suffering and hanging in there to keep the other one happy. But in a nutshell, the main reason that I don't have a regular problem with panic attacks is because I was easily able to identify it for what it was, recognize that it wasn't dangerous or fatal, and not develop that fear of fear. And so I like to share that story because, I mean, it highlights a real panic attack, but it also highlights the power of just being informed regarding what's going on. I sometimes will tell students that to a degree, this class can be a little inoculative against developing certain disorders, because with many, it's much less scary when you understand what's going on and you understand that there's a name that goes with your experience. And so, yeah, that kind of highlights the power of knowing about this stuff, and that if you can really break the fear of fear, you can break the panic loop for folks with panic disorders. The final pieces of diagnosis are rule outs. You guys will see this as a part of each set of criterion that we talk about in this class. Rule outs mean that we want to make sure that there aren't any other explanations for what is going on. So we wouldn't diagnose a panic disorder if, for instance, a person had a general medical condition like a heart condition that was causing some of these cardiac symptoms. We would want to rule out the presence of a cardiac situation or rule out the presence of like a stimulant high as the reason for the symptoms that we're seeing. We also want to rule out other mental disorders. So namely speaking, other anxiety disorders, things like social anxiety, phobias, PTSD, OCD, things of that nature. Panic disorder is relatively rare. It impacts about 2 to 3% of people, most commonly females and non-Hispanic whites. The average age of onset is early adulthood, so early 20s. And the lifetime prevalence of panic attacks, not panic disorders, is 30%. So about 1 in every 3 adults has experienced a panic attack over the course of their life. So I always like to share that with clients when I'm working with them on panic attacks, is that by themselves, they're very common. They're very safe. They are not fatal. And again, to try and normalize some of that sensation and really counter the fear of fear, which is what makes panic attacks so much worse than they are. In addition to diagnosing a panic disorder, you could also potentially diagnose a person with a panic attack specifier. This means that you're observing panic attacks and they're recurrent, but they're not unexpected or uncued. Rather, they are cued, they are expected. So if I regularly had panic attacks every time I was in an enclosed space, that's what would be called an expected or cued panic attack. It's not random, it is associated with a reliable event. And panic attacks may ultimately be associated with really any mental disorder, any general medical condition. And so if we're observing a cued or expected panic attack, what we would diagnose the person with is we would diagnose them with whatever the mental disorder in our case, because we're talking psychology and the diagnosis of mental disorders, not medicine and the diagnosis of medical conditions. So we would diagnose the person with whatever mental disorder the panic attacks are associated with. So again, to use me as an example, let's say that I have panic attacks every time I'm in a claustrophobic type situation. That is a type of specific phobia. So I would be diagnosed with a specific phobia with panic attacks. So anytime we're diagnosing a specifier, it's this kind of added little piece that we put on the end of a diagnosis. It's like a secondary piece of information. And throughout this course, I'll be introducing not only primary diagnoses, but I'll also be introducing specifiers, pieces that you may specify at the end of a diagnosis, kind of adding in additional information. And those specifiers are things that you'll be diagnosing on exams as well. So it's important to kind of be familiar with specifiers and understand how to use them. So again, how this one works is you would diagnose the mental disorder that the person has that is reliably associated with the panic attacks. And then at the end of that diagnosis, you would specify with panic attacks to communicate that panic attacks aren't normally a part of this presentation, but for this person, panic attacks are an additional piece of what's going on. And again, we refer to these as expected attacks. Unexpected attacks exclusively are associated with panic disorder. We sometimes refer to these as false alarms, because when we think about it, a panic attack is really like a very specific type of anxiety. It's this intense flood of physical sensations that's alerting you to possible danger. And so when we've got the cued kind of attack, it makes sense. Your body is responding to a cue or trigger, and is alerting you to it. So to a degree, the random ones that happen with panic disorders are kind of like false alarms, because they're not really providing helpful information. They're just really, really random in nature. And like I mentioned before, we might even have super strange random ones like nocturnal panic attacks. And those are going to be particularly rare. For people who have more regular attacks, so about a third of people with panic disorder will start to see nocturnal attacks. So for about a third of people diagnosed with panic disorder, we'll start to eventually see nocturnal panic attacks creep up, even if they weren't an initial part of presentation, just because the uncued nature of panic disorder is so pervasive, and panic attacks will just start occurring and continue to occur in random situations. And a decent chunk of people will eventually develop nocturnal panic attacks. And again, that is just people with panic disorder, not just the general population. Up next is a diagnosis that is closely related to panic disorder. It's something called agoraphobia. This is going to be first and foremost marked fear or anxiety about two or more specific situations, specifically public transportation, open spaces, enclosed spaces, crowds, or leaving home alone. So the person must be afraid of or anxious regarding two or more of those 5 situations. So those aren't example situations, those are a concrete list of 5 that we have to choose from. Next, the individual will fear or avoid these situations, namely because escape may be difficult or help unavailable if panic-like or embarrassing symptoms were to occur. So the reason for fear or avoidance is the person is afraid they won't be able to get out, or that help won't be available if they have a panic attack or something unrelated but embarrassing happens, like fainting, falling, incontinence. The situations almost always provoke fear or anxiety and are actively avoided, require the help from a companion, or are endured with intense fear or anxiety. The fear or anxiety experienced is out of proportion with the actual danger. So we're kind of getting into the territory of anxiety that's not really helpful. It's not like we're reacting to something that is dangerous, like a tiger, right there in front of us. We're reacting to something that is not threatening. And the fear, anxiety, or avoidance is persistent, lasting at least 6 months. There is demonstrable distress or impairment, and we're ruling out other causes, including medical conditions like Parkinson's disease and other mental disorders like phobias, PTSD, body dysmorphia, and social anxiety. So the big takeaways here that we're avoiding at least 2 of 5 situations, and that the reason is because help may be unavailable if panic or embarrassing symptoms were to occur, or because escape might be difficult. The reasoning is important because on the surface, agoraphobia looks a lot like social anxiety, which I'll introduce to you guys next. And the reasoning is one of the pieces that separates those 2 diagnoses. So as you might have guessed, agoraphobia is very closely related to panic disorder. In fact, panic-like symptoms is listed as a part of the criterion for agoraphobia. In the DSM-4, the diagnoses were actually linked. A person would be diagnosed with either panic disorder with agoraphobia, panic disorder without agoraphobia, or agoraphobia without panic disorder. So even if only one was present, the label on a patient's file would reference the presence of the other. So they are very closely linked, but I do like to point out that embarrassing symptoms can also be associated with agoraphobia. So again, a person could develop agoraphobia out of a fear of fainting, falling, incontinence, something completely unrelated to panic. 30 to 50% of folks with agoraphobia report panic attacks or panic disorder preceding the onset. So again, a good chunk, but not everybody. The prevalence is similar to panic disorder, about 1 to 2% of the population, again, more common in females, and the average age of onset is going to be similar to panic disorder, late adolescence, early adulthood. There are some cultural variations in panic-like symptoms to be aware of. These are things that would be listed in the culture-bound section of the DSM. So attack de nervios is a Latinx presentation that includes unique symptoms like screaming unconsciously in a potentially nocturnal situation or physical aggression, in addition to some of the more Western Americanized symptoms that we've already covered. Agoraphobia tends to have a more chronic course. About 10% of folks with agoraphobia fully remit, meaning they fully recover. About 30% are completely homebound or otherwise unable to work, and about 50% rely on financial assistance. Depression and suicidal thoughts are also common. So I point that out because not to say that treatment is hopeless, but I always like to highlight for students disorders that are very treatable versus disorders where it's a bit more of an uphill battle. Panic disorder, very treatable. You're really doing exposure, which I introduced you guys to previously, and we'll talk a little bit more about towards the end of class. But you're also trying to break up that fear of fear, very doable. Agoraphobia is just a bit tougher, and there's a lot of impairment that comes with it. Difficulty working, difficulty leaving the home, difficulty earning a living, as well as other mental health concerns. Generalized anxiety disorder, or GAD, is a funky anxiety disorder. I almost prefer to teach this alongside depression, just because it behaves a little bit more like depression and other mood disorders than it does anxiety disorders. But the APA's listed it as an anxiety disorder, and I mean, the name includes anxiety, so it makes sense why they do that. But I do just like to always kind of, I guess, preface this disorder that way, because it just behaves a little bit differently than some of the other things we'll be talking about today. So GAD is excessive anxiety and worry. We sometimes refer to this as apprehensive expectation. Apprehensive expectation basically just means that the person is anxious about something that has yet to happen, occurring more days than not for at least 6 months about a number of events or activities, including things like work, health, finances. So we're not talking about someone who is worried about academics, period, or someone who's worried about their budget or their finances, period. We're talking about people who are worried about a variety of things. In addition, the worry is very difficult to control. We're also going to see this apprehensive expectation associated with at least 3 symptoms, only 1 if we're talking about children. These symptoms include restlessness, fatigue, difficulty concentrating, irritability, muscle tension, as well as sleep disturbance, which is a broad term that can encompass anything from insomnia to restless sleep. I've highlighted several of these symptoms in red: fatigue, difficulty concentrating, insomnia, to highlight that these are also symptoms of major depression. And I've underlined insomnia as well to highlight that this is an independent sleep disorder as well. I like to highlight these pieces for students in this particular class as a prime example of symptom overlap between diagnoses. So you'll notice again that we're only looking for at least 3 symptoms, but if those symptoms are fatigue, difficulty concentrating, and insomnia, diagnostically that can leave us in a little bit of a pickle, because those are also symptoms of major depression, and one of those is a sleep disorder by itself. And so this is a good example of where differential diagnosis comes in. This is another good example of just kind of why it's more common these days for patients to have more than one diagnosis than just one, is sometimes a person's got that perfect constellation that is applicable to multiple labels, and so they end up leaving with multiple labels because they meet criteria for multiple things. My personal approach, which I've mentioned previously, is to really only diagnose secondary and tertiary diagnoses if those additional labels explain additional pieces about the person. I don't like to give multiple labels that explain the same set of symptoms. So unless I truly feel that we're dealing with both GAD and major depression, and there are a few cases where I do feel that both labels are bringing something to the table, most of the time I will sit and figure out which one of these two I feel is the best explanation for what's going on. In addition, we need to see distress impairment, and we also need to rule out other causes, including the effects of substance, either intoxication or withdrawal, medical conditions like hypothyroidism, and other mental disorders like panic, social anxiety, PTSD, and body dysmorphic disorder. In terms of features, this impacts about 3% of adults. It's more common in females and non-Hispanic whites. The average age of onset is adulthood, although many report having been anxious their entire life. And so GAD is kind of one of those interesting ones that is a bit more chronic, and people typically don't show up for therapy until it's either been going on for so long that they finally break down and go, or something else happens. And they end up presenting for therapy, and in taking a history, it's kind of revealed that they've been chronically anxious as well. Common worries include future events, past transgressions, financial matters, own or others' health, and job performance. This is usually pretty chronic, although the symptoms may wax and wane, meaning this person might go through periods where the worry is better or worse. I do think it's important in talking about GAD, the difference between the clinical diagnosis and normal worry. And so I provide this chart to help break down some of those differences. So GAD is going to be where worries are very excessive, they interfere with daily life, versus normal worry is something that's not excessive, it's perceived as manageable, controllable, it's something that's weighing on you, but it's not really kind of overtaking your life. GAD, we're seeing worries that have a longer duration. They're also less likely to be cued, so they're lasting longer and they're just kind of always there, versus normal worries, time limited, it's cued. So it's, you know, I'm about to graduate and so I'm worried about that, or I'm about to buy a house and so I'm worried about that. Versus GAD, we're dealing with stuff that's more chronic and just kind of always there. And when one thing is solved, you know, we're dealing with almost like a neurotic brain that's just going to replace that worry with another worry. There's also a greater range of worry and physical symptoms with GAD versus with normal worry. It's focused generally on a particular problem, and we're not seeing that replacement behavior where one worry kind of goes away and we just kind of almost find something else to worry about. There also aren't any physical symptoms associated with normal worry. Social anxiety disorder, or social phobia, is the disorder that I mentioned earlier that can, on its surface, appear very similar to agoraphobia, and so it is important for you guys to be able to know how to differentiate the two. Here we're dealing with marked fear or anxiety about one or more situations in which the individual is exposed to the scrutiny of others, for example, social interactions, being observed, or performing in front of others. In children, anxiety must also occur in peer settings, not simply with adults. So here we've got our first difference between the two diagnoses. In that we're looking at a variety of situations. The DSM here provides examples of types of situations that might kind of fit the bill, but we're not working from a fixed list. Second difference is the reason for the anxiety. So with agoraphobia, we're dealing with specifically the worry that a person won't be able to escape or that help may be unavailable, versus here, the reason is because of the possible scrutiny of others. Criterion B is that the individual fears that anxiety symptoms will lead to negative evaluation. So the person is afraid that they will begin sweating or shaking, any of the anxiety symptoms we've talked about previously, and that others will observe those symptoms and evaluate them negatively, meaning that they will reject, criticize, scrutinize that individual. Social situations almost always provoke fear or anxiety. In children, we're less likely to see the physical symptoms of anxiety or avoidance. We're more likely to see crying, tantruming, freezing, or clinging, which are common childhood expressions of anxiety that you guys will see pop up in additional diagnostic criteria. Social situations are either avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion with the social context. Fear, anxiety, or avoidance is persistent, lasting at least 6 months. There's demonstrable distress or impairment. We're ruling out substances or medical conditions, as well as other mental disorders, including panic, body dysmorphia, and autism. And if another medical condition is present, for example, something like Parkinson's or obesity, the fear, anxiety, or avoidance is unrelated or excessive. Meaning that if a person has something like Parkinson's, where tremors are common, or obesity, where we might see like sweating, for instance, that this person's reaction to those symptoms and fear of that negative evaluation is out of proportion, even given that diagnosis, or that the person's fear or anxiety and focus on negative evaluation and social rejection is completely unrelated to the medical condition. This one is going to be the most common one that we've discussed thus far. It impacts about 7% of adults. Common temperaments include folks that are shy, submissive, or less commonly controlling. Self-medication with substances is very common, so it's pretty typical to see someone come in with social anxiety, and it might not be diagnostic, but I find that alcohol use problems or concerns, even if not kind of fully diagnostic, are common associated features, and it's because alcohol it's a depressant. So from a chemical point of view, it is doing the opposite of what anxiety is doing, and it's functioning as a social lubricant. So sometimes people can develop alcohol use issues because they're using alcohol to self-medicate in social situations. Again, more common in females, as is the case with many of the anxiety disorders. The average age of onset is adolescence, so we're talking typically those middle school, high school, teenage years when social pressures really start to weigh on folks. This one comes with some possible impairments to be aware of as well. School dropout is more common, as is unemployment, social isolation. As adults, if this persists without treatment, it's also more likely that folks with social phobia are going to be unmarried without children. Not everybody, but just more commonly, especially if the person is older, further into adulthood, and never grappled with their social anxiety or went through treatment at a younger age. Common fears include showing anxiety symptoms, being judged as boring or unlikable. Public urination may even be a common fear for some folks. The core of this is really that these folks tend to overestimate the negative consequences of social situations and underestimate the likelihood that things will be fine. Also, of course, any fear has to be out of proportion to the situation, meaning that if a reasonable situation like bullying is going on. So let's say we've got a teenager who's being bullied and as a consequence is anxious about being not liked or evaluated negatively, which makes sense because we've got a bully who is negatively evaluating this person and who doesn't really seem to like this person. In order to diagnose a social anxiety or social phobia, we need to make sure that the reaction is out of proportion. So if there is a reason like bullying, in order to diagnose this, the reaction has to be above and beyond what we would expect to be a typical normal reaction to bullying. We may also diagnose a performance-only specifier. What this means is that the fear is restricted to speaking or performing in public. And so the fear is really focused more so on one's performance being evaluated than one's social skills being evaluated. And the most common form of this that we will see is like a public speaking fear, or sometimes like a testing anxiety. So this person's very confident with their social skills, but they worry that a specific type of performance will be negatively evaluated. Ultimately, folks with a performance-only specifier have a better prognosis with less severe anxiety, fewer depressive symptoms, and minimal social skills deficits. Specific phobia is the second type of phobia that we'll talk about today. This is a marked fear or anxiety about a specific object or situation, including things like flying, heights, animals, receiving an injection, or seeing blood. Again, children may express that telltale childhood presentation of crying, tantruming, freezing, or clinging. The phobic object or situation almost always provokes immediate fear or anxiety and is actively avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion with the actual danger given the sociocultural context and is persistent, lasting at least 6 months. We're dealing with distress and impairment here, as well as ruling out any other potential causes, including other mental disorders like OCD or PTSD. So basically, we're having an excessively fearful or anxious reaction to a specific object or situation that could potentially result in avoidance of that object or situation. So very much what Miriam was demonstrating to us in that video that we watched earlier. This one ultimately impacts about 5% of kids, 16% of teens, and 6% of adults. The average age of onset is childhood to adolescence, which you can kind of pick up on based on those prevalences. But also, we do see that these wax and wane with age, and that many people grow out of their phobias. If, however, a phobia persists into adulthood, it's more likely to be chronic. So if a person hasn't grappled with their phobia earlier, it's more likely that it's going to stick around for a while. The development is typically linked to trauma, observation, an unexpected panic attack that is poorly understood. So the person has a random panic attack where their sympathetic nervous system goes off, again, completely fine. Not dangerous. The person doesn't understand that and instead associates the panic attack with whatever they were doing at the time and develops a phobia. People can also develop phobias through information, meaning that a person may learn a scary fact, like learn a scary fact about elevators and develop fear of elevators. The observation type would be like watching a scary movie with like a big snake or something and developing a fear of snakes that way. Or alternatively, evolution, which I'll talk about in the next slide. So there are a handful of phobias that we're more evolutionarily predisposed to. And so genetically, that can be an explanation for why some folks develop phobias as well. For a person who has a phobia, it's more common to have multiple. The average is about 3. And with specific phobias, we must specify the source of the phobia. So anytime you diagnose a specific phobia, you need to include what type it is that you're dealing with. Animal would be any animal-based phobia. So spiders, insects, dogs, etc. Natural environment is any phobia relating to a natural environmental scenario like heights, storms, water. Blood injection injury is going to be any fear relating to blood injection or injury, including needles or invasive medical procedures, the dentist. Situational would be any situation that is not accounted for in the natural environment category. So this would include airplanes, elevators, enclosed places. And typically there's a later age of onset for these. These aren't quite as primal as the animal, natural environment, and the BII phobia. And so typically we're dealing with more of a teenager, maybe even an adult who's developing these. And then of course we have an other category, which would be anything that's not accounted for in the other 4 categories. So this could be situations that lead to choking or vomiting. Some people have fears specifically of those things. Loud sounds, costumed characters, clowns, all that stuff would fall in the other category. Again, more common in females than males, but the rates do vary by phobic stimulus. Females are more likely to have animal, natural environment, and situational phobias, but both males and females are equally likely to have blood injection injury or BII phobias. BII phobias are interesting. They're common, but they're different from other phobias in a very significant way. Unlike other phobias, which are associated with activation of the sympathetic nervous system, so heart racing, sweating, difficulty breathing, etc., BII phobias are associated with parasympathetic activation. More specifically, people will commonly show something called vasovagal syncope, which is a combination of bradycardia, or a slow heart rate, hypotension, or low blood pressure that can ultimately lead to fainting. One of the reasons for this is because of the fact that anxiety is designed to help us deal with threats. And with most threats, you want to get out of there. You want to fight or flee and get away. And so that's what the sympathetic nervous system is aimed at. So if there is a snake or a tiger, or you're up high, it makes sense to get out of there. But with the BII phobias, the fear is really focused more so around injury. And if you're injured, it does not make sense to pump a bunch of blood to your muscles, because if you're injured, you could actually bleed out in that situation. And so if what we're afraid of in this scenario is injury, what your body is going to do is slow down, because if you are actually injured, we don't want your heart to beat faster. We don't want your blood pressure to go up. We want to slow down, maybe even lay down. And so if you think about what makes sense adaptively to do in different situations, it makes more sense why physiologically we respond differently to different types of situations, and why the BII phobia is so different. Evolutionarily, circling back to that piece I mentioned earlier, this is a chart that lists out the most common types of phobias. You'll see up at the top that we've got a lot of really primitive things: insects, snakes, birds, other animals, heights, being in closed places, flying, being in or on water are some of the top 5. And many of these are very primitive types of things. We really start to see more modern types of things the further down on the list we go. And some things that aren't on the list include things that are legitimately fearful to us today, like guns or highway accidents, things that people don't tend to really be afraid of, but things that are realistically more dangerous to us than things like snakes and insects. Yet the reason why some of these things are dominant still, despite the fact that they're not really contributing a lot to death rates or morbidity, is because of the evolutionary nature of phobias. If we have an ancestor, a distant ancestor, who had a healthy fear of some of these things, they were more likely to survive and pass that healthy fear on epigenetically to the next generation, and so on and so forth. And so today, you've got folks in Alaska where snakes are non-existent who still have snake phobias. So I always like to kind of introduce that concept in discussing phobias, because there's definitely a very strong evolutionary basis to many of the more common ones. So that concludes our discussion of anxiety disorders, and now we're going to move on to trauma and stressor-related disorders. First and foremost of which is going to be PTSD, or post-traumatic stress disorder. First and foremost, we need exposure to a trauma. So that's what criterion A is all about. So we need exposure to actual or threatened death, serious injury, or sexual violence in at least one way. So with PTSD, we're dealing with what I like to call the big traumas: death, serious injury, and sexual violence. And depending on which ones we're talking about the actual thing, or in some cases, a threat. So that is what we're focusing on. And there are multiple ways that a person could be exposed to one of those things. One is through direct experience, where the person was threatened with death, injured, exposed to sexual violence. Witness would be observing that happening to another person. The person could also learn of an event in a close family member or friend. So this has to be someone the person is really, really close with. So close, in fact, that simply learning that, your mother um, experienced sexual violence, or that your brother was seriously injured, that simply learning that you weren't even there, you didn't even see it, but learning about it is enough to traumatize a person. Or the repeated experience type, which we see most commonly in first responders, EMTs, firefighters, police officers. These are folks who there's not one particular event that happened, but this person's job or their lifestyle so routinely exposes them to things that could be traumatic that it's kind of the cumulative add up of all of these things that leads to PTSD. So there's not one particular highway accident. It's the fact that this EMT is responding to highway accidents again and again and again to the extent that they develop PTSD. So that's kind of part one, is exposure to trauma. The subsequent symptoms all have to do with the post-traumatic stress response, which is the second and equally important component of diagnosis, because as you guys will see on subsequent slides, trauma does not equal PTSD. Not everybody who is traumatized has this constellation of symptoms that comes afterwards. And so in many ways, that's really what makes PTSD PTSD. And there are several different types of symptoms that we're looking for. Specifically, we're looking for intrusive symptoms, indicators of avoidance, negative changes in thought or mood, and marked alterations in arousal and reactivity. So let's go through what each one of those means. So criterion B is going to be the presence of at least one intrusive symptom associated with the traumatic event. This could include recurrent intrusive memories, recurrent distressing dreams, dissociative reactions like flashbacks, or cued distress or physiological reactions, meaning there's some cue or trigger reminder of the trauma, and we're experiencing distress or physiological reaction in response. So we need one indicator of intrusion. Criterion C is going to be persistent avoidance of stimuli associated with the traumatic event, and this has to be evident in only one way. So this could be avoidance of what I like to call either internal or external reminders. Avoidance of internal reminders would include things like memories, thoughts, or feelings. So a person may develop a substance abuse problem as a way to internally distract from thinking or feeling a particular way. Or we could be dealing with external avoidance, which might include things like avoiding people or other physical reminders of the trauma. Criterion B is going to be negative alterations in cognition or mood, and this we're looking for two symptoms, not just one. This includes an inability to remember aspects of the event. So we might have kind of foggy or completely blacked out memory in general, or for pieces of what happened. We might have persistent, exaggerated negative beliefs like I am bad or I deserved this. The belief has to basically just be negative, exaggerated, unrealistic in nature, and persistent. Distorted cognitions about the cause of the event. So incorrectly blaming oneself when that wasn't the case in terms of what happened. Persistent negative emotions, anhedonia, which is a fancy word for loss of interest or enjoyment in things that were previously pleasant. So you've got a runner who now can't bring themselves to go for a run, for example. Feeling detached from others, or a persistent lack of positive emotions. So at least two of those. And then finally, criterion E is marked alterations in arousal and reactivity, again, evident in at least two ways. So for the first two categories, we're looking for one symptom, criterion B and C. And then for the second two categories, criterions D and E, we're looking for two indicators in each of those categories. So symptoms here include things like irritability or aggression, reckless or self-destructive behaviors, hypervigilance, an exaggerated startle response, so someone who's very jumpy, very alert, difficulty concentrating, or sleep disturbance, which includes things like insomnia, restless sleep, very similar to what I talked about in terms of GAD. The disturbance must be persistent, lasting at least 6 months. There has to be distress and impairment, and we have to rule out other potential causes, including substances and medical conditions. This impacts about 9% of adults. The highest rates of developing PTSD are among veterans and first responders, these folks have high rates of developing PTSD, but the highest rates are among rape survivors, those held in captivity, and those who experienced genocide. About 30 to 50% of folks who go through those experiences end up being diagnosed with PTSD. So those are the top 3 categories, but then beneath that, we've got vets and first responders. Symptoms usually present within 3 months, so pretty soon after the trauma. Although we may see subthreshold presentations more common later in life, meaning that a person may develop symptoms later on, but they're typically not going to meet full threshold. So if a person's going to meet criteria for PTSD, they basically tend to do it pretty immediately after the trauma. But if we've got more of a delay where months pass and we really only see symptoms, 6 months to 12 months later, it's unlikely that they'll develop the full 6 symptoms at least that they need to be diagnosed. Not to say that that's not worth addressing in therapy, but just the PTSD wouldn't be the appropriate label in that scenario. Recovery really ranges. It depends on what the person's coming in with. Are we talking one trauma, multiple? PTSD is definitely treatable, but it can be a long road to recovery. In addition, because we are dealing with more and more mass traumas within the past couple of decades, there are some additional considerations to just be aware of with those types of events. One is that proximity tends to determine risk for developing PTSD. I always use the example of 9/11 in talking about proximity with PTSD. So you can see that there is a map on the far side of the screen of Manhattan with the World Trade Center site identified there at the bottom. And for folks who were south of Canal Street in that orange area, when the planes hit and the towers came down 20 years ago, there was about 20% likelihood of those folks developing PTSD. But for folks who were still in Manhattan, still in New York City when this happened, but we're simply a little bit further north between Canal Street and 110th Street, the yellow area, only about 7% of those folks develop PTSD. So this is going to be an important nugget to kind of file away if you do end up working in first response, or if you do end up working in an area where there is a mass trauma, that it is important to kind of triage people, not exclusively based on proximity, but it can be important to inquire about proximity, because the closer someone was to a quote unquote ground zero of an attack or mass trauma, the greater the likelihood of developing PTSD later on. Beyond that, people may also traumatize themselves through electronic or media exposure. This is something that we've seen more and more as traumas aren't just experienced in person, but as we have 24/7 news sources that cover trauma around the clock, news around the clock, but news tends to be more negative than positive these days. And so it's really possible, if you want to really marinate yourself in just like really bad traumatic news day in and day out if you want to, and can kind of traumatize yourself that way. So this electronic version in which we can view trauma has contributed to something called conceptual bracket creep, which basically means that when the APA first conceptualized PTSD and wrote about in the DSM, they had this idea of what PTSD was, which is the definition on the previous slide. We're dealing with certain types of trauma. We're dealing with direct experience, witnessing, learning about it in a loved one, repeated exposure, and that's it. But now technology is kind of challenging that definition, and we're basically at a point where we have to determine, do we include the electronic stuff or do we not? Do we decide that that's something else and either let it be or maybe even create another label for that? The estimated trauma prevalence across adults is about 90%. It's a very high number, but when you really think about what trauma is, and you think about a person's lifetime, it is likely that they will experience something that is considered traumatic. That being said, 90% of adults do not have PTSD. Only about 10% of those who are traumatized eventually develop PTSD. So again, why it's important to really look for those additional symptoms when diagnosing this one. PTSD may be evident in children under 6. In addition to that, we might just see PTS, so just post-traumatic stress. We might not see a full-blown disorder. And that's really what I'm going to be focusing on in this slide, is just indicators of trauma and a stress response in kids. And I'm going to introduce some additional disorders that are really childhood specific and related to different types of stress. Some things to just kind of keep in mind. These are not criteria. I like to introduce these more as kind of like warning signs or pieces that might help you understand conceptually what's going on with kids more, are that if a child has been traumatized, they may lack a clear understanding as to what happened. And so they might not really be able to communicate or describe what they experienced or observed, unlike an adult. So an adult can say, I experienced this, or I saw this and I'm feeling this way as a consequence. Kids aren't going to be able to articulate in that way. And so for that reason, it's important to know warning signs of when a child may have been traumatized. Not guarantees, warning signs. These are basically indicators that I would suggest following up clinically or medically to really kind of try to figure out what happened. So violent play themes could be an indicator of trauma. Unrecognizable nightmares, where a child wakes up repeatedly night after night, scared, but can't really describe what happened. It was just a scary dream. Social withdrawal, where we're not wanting to spend time with other people or certain people, or alternatively clinging to a safety person. And then developmental regression, where previously we were potty trained, but now we're not. We were sleeping with the lights off, but now we're not. These are all going to be, again, warning signs, red flags, not diagnostic, warning signs or red flags. And more specifically, reactive attachment disorder and separation anxiety may be related to specific childhood experiences. And so these are going to be the last two that we learned about today. Reactive attachment disorder is consistently inhibited and emotionally withdrawn behavior toward adult caregivers, manifested by both rarely or minimally seeking comfort when distressed and rarely or minimally responding to comfort when distressed. So inhibition, emotional withdrawal toward adult caregivers, manifested by not seeking comfort or not really responding when comfort is offered. That's really going to be criterion A. Criterion B is going to be persistent social and emotional disturbance, characterized by at least 2 of these 3 things: minimal social or emotional responsiveness to others, limited positive affect, and episodes of unexplained irritability, sadness, or fearfulness, evident even in non-threatening interactions with adult caregivers. So we're combining in the socio-emotional piece that is demonstrated in a couple of different ways. Criterion C is a pattern of extremely insufficient care, evidenced by at least one of these situations: social neglect or deprivation in the form of lack of having basic emotional needs met by a caregiving adult. So neglect is a way to think of that one. Or repeated changes in primary caregivers that limit the opportunity for stable attachment. So this could be like moving around a lot, like in foster care. And it's not as much that anybody was neglectful, it's just the child is moving so often that they can't really bond or attach to anybody. Or C, child rearing in an unusual setting that would limit opportunities for such selective attachments. So that could be being brought up in, again, I already gave kind of repeated moves that sometimes, not always, but sometimes can happen with foster care, or being brought up in more of like an orphanage type scenario, or something of that nature, where you're not really being moved so much, or seeing different caregivers, as there are just fewer opportunities to really kind of bond in that scenario. So we don't need to see all, but we need to see one of those. So collectively, we're kind of looking at this inhibition, emotional withdrawal, some socio-emotional impairment, and all of this is going to be prefaced by insufficient care, either neglect or not having had the opportunity to attach or bond with an adult, which is where criterion D comes into play. Criterion A has to begin following criterion C. So the insufficient care scenario has to be in place first, which then sets the stage for everything that we see in criterion A. We want to make sure that we're ruling out autism, which could be an alternative explanation for particular types of inhibition or socio-emotional types of symptoms. We need to make sure that we're seeing symptoms prior to age 5 and that the child is at least 9 months old. Separation anxiety disorder is developmentally inappropriate or excessive anxiety concerning separation from those to whom the individual is attached, evidenced by at least 3 of the following symptoms. Recurrent and excessive distress when anticipating or experiencing separation from an attachment figure. So that's kind of the bread and butter, I would say, of this diagnosis is separation is happening or it's impending, and we're seeing a lot of distress. Persistent and excessive worry about losing an attachment figure. So this might be a child who the attachment figure is there, like mom is there, but we are really worried that she is going to get sick, injured, or die. Similarly, we may see persistent or excessive worry about some kind of untoward event like kidnapping that could cause separation. So again, this hasn't happened, but child is spending a lot of time worrying about some type of event that would separate them from their attachment figure. We may see reluctance or refusal to go out or away from safe zones such as home or school. We may see excessive fear of being alone or without one's attachment figure. We may see reluctance or refusal to sleep away from home or go to sleep without the attachment figure. We may see nightmares relating to separation, and we may see complaints of physical separation, such as stomach aches during separation. Anxiety is persistent. Obviously, you see that word popping up with a lot of these symptoms, lasting at least 4 weeks in children and teens, and at least 6 months in adults. So definitely way more common in children, teens, but technically possible in adults, unlike the reactive attachment that we talked about previously. Distress and impairment, of course, and ruling out other causes, specifically other mental disorders, including autism, psychosis, agoraphobia, generalized anxiety, and illness anxiety. So features collectively of both. Reactive attachment is very rare, less than 10% of severely neglected children. So even in those scenarios that I listed out for you under criterion C, less than 10% of those kids are being diagnosed with this. So this is a very rare presentation. As I mentioned, may be associated with specific upbringings like frequent changes in foster care, institutions with high child to caregiver ratios or law of turnover, and reactive attachment, if diagnosed, may also be associated with developmental delays as a consequence of basically failure to attach at the expected age. As far as SAD, as far as the separation anxiety goes, this impacts about 1 to 2% of children. Some is part of normal early development. So actually seeing some anxiety about separation around the 1-year mark is going to be considered a sign of secure attachment. So it is important to, if you're thinking about working with kids, definitely taking a developmental psychology course to better familiarize yourself with what's typical and what's not for different age groups. Because at least as far as this one goes, separation anxiety to a degree is considered more normalized at certain ages, but then there is an age where it's less expected, and that's kind of where we get into more of the diagnostic territory. Typically, this one is onset by life stress. And so frequently we'll see like death of a pet, death of a family member, immigration, separation from family, like what we've been reading about happening at the border. These can all be things that can kind of trigger this for folks. So you can see that situation is a really powerful trigger for both of these. Okay, so those are disorders. So we're gonna wrap up today by discussing really briefly some causes, and we've already talked about the behavioral theory. So that kind of laid the groundwork for treatment, but we'll touch again on exposure types of approaches as well. So etiology. First of all, a general fact when reading about etiology or any other kind of statistic, informational bits relating to diagnosis is that anytime a new edition of the DSM comes out, typically it takes several years for information to be updated to those new criteria, which is especially noteworthy if the criteria changed at all. So fortunately for the anxiety and trauma and stressor related disorders, there weren't really any major changes. So anything you read about the anxiety disorders for the most part, regardless of when it was published, whether it was using DSM-4 or DSM-5 criterion, that they're the same, and so there aren't any big differences. But it is important to be aware of as we get into other disorders that did change between the DSM-4 and the DSM-5, is that initially a lot of research coming out around the time of that change is going to be referencing older editions of the DSM until research kind of has time to catch up with the new stuff. So I just always like to point that out. At this point, the DSM-5 came out in 2013, so a good chunk of time has passed. So everything at this point that's out should be referencing DSM-5, but just kind of a little nugget that I like to throw out there, just kind of for your consideration, because if you end up practicing in this field, a new edition will eventually come out. So just, I guess, be aware. So as far as causes of anxiety and trauma go, there are a couple different things going on. Genetically, there's a little bit of genes going on here, but not quite as much. There's a 34% concordance rate amongst monozygotic twins and a 17% concordance rate amongst dizygotic twins, meaning that if one fraternal twin is diagnosed with an anxiety disorder, there's a 17% chance of the other twin being diagnosed. If an identical twin, monozygotic, is diagnosed, there's a 34% chance of the other identical twin being diagnosed. So that's typically one way that we'll gauge genetics. These are relatively low numbers. So yes, genes do play a role in anxiety, but the environment and personality are much stronger drivers of these diagnoses. Environmentally, childhood maltreatment or adversity, parental overprotectiveness, stressor exposure are going to be keys. From a personality point of view, being sensitive to anxiety, just more responsive to anxiety. Negative affect, so having any of the traits associated with a neurotic mood, which include hostility, irritability, anger, depression, sadness, anxiety, fear. These are all going to be things associated with these diagnoses. Also being a bit more inhibited or shy behaviorally can be causal pieces as well. Physiologically as well, there are several regions of the brain that may be involved in an anxiety diagnosis, such as the prefrontal cortex, the hippocampus, and the amygdala. The prefrontal cortex is the part of the brain that's responsible for thinking and logic, and so sometimes this part of the brain can be overestimating the likelihood of a negative outcome and underestimating the likelihood of a realistic outcome. And so logically, there could be some errors there. The hippocampus and the amygdala collectively are responsible for memory and emotional processing. And we see these pieces being active in a lot of mental health diagnoses where a person is having a different emotional experience and is very sensitive to memories associated with that particular emotion, in this case, anxiety and fear. Treatment for the anxiety disorders, as I mentioned earlier, the number one kind of approach is going to be exposure therapy. It's the treatment of choice for anxiety, trauma, and stressor-related disorders, as well as obsessive compulsive disorders, which we won't get to until unit number 2. Exposure basically means facing one's fears to get over them, and this is the heart of treatment. You saw this demonstrated in Miriam's video, which you've already watched. And there's several different approaches. You can do this in vivo, which means in real life. You can do it where you have the person imagine exposure scenarios. You can also do it virtually as well, which is an approach we're seeing utilized more and more for veterans. When done correctly, about 70% of people with anxiety disorders show improvement, and that number is highest for specific phobias, which are a very responsive category. The recovery rate is 80% of folks in that category going through this approach. The only real exception seems to be combat-related PTSD. We see a somewhat lower rate of recovery for that particular diagnosis. But across the board, anxiety disorders, really kind of everything we've talked about, respond really, really well to this approach. Excluding combat-related PTSD, remission rates are 93% after 2 years and 62% after 10 years, meaning that some follow-up may be needed, but those are still extremely strong numbers. The key as far as therapy goes may be working with your client to develop creative and appropriate exposure situations. I really enjoy that part of treatment. I didn't think I'd like working with anxiety disorders as much as I do, but I love it. I love working with really everything we talked about today. And part of it is kind of the collaborative approach to treatment and figuring out, okay, how can we help you face your fear in real life through imagination? I don't work with VR. Basically, to use that approach, you need to be going to like a vet center in like a big city. But in real life, using imagination, using narrative, those are the types of things that I do. And so one of the things I want you guys to reflect on that we will talk about in class next time we meet is think about these different cases on here. Maria, Jeff, Carla, how might you design an exposure-based approach for each of these clients? So think about it, try to get creative, and we'll talk about different approaches and how you might use this general face your fear exposure type paradigm to help each of these individuals as our jumping off point during our next class. All right, hope you guys enjoyed, learned a lot. I would definitely recommend watching this one twice, once when it's assigned and a second time at least, leading up to the role play and the first exam. All right, that's all I got for y'all. See you later.